Hello, I'm Chris Cowley. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for episode 3 of a 4-part CMEOCast series on best practices to improve screening and treatment of hepatitis B virus. Today's episode is titled Public Health Opportunities in the Emergency Department, Step 1, Screen for HBV, and Step 2, Link to Care. This activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. As I mentioned, I'm Chris Cowley, Director of Liver Institute Northwest in Seattle, and a clinical professor at the Elson S. Floyd College of Medicine at Washington State University, which is based out of Spokane, Washington, but has teaching sites all over Washington State. And I'm delighted today to be joined by my colleague, Carlos Malvestuto. Carlos is an assistant professor in the Division of Infectious Diseases at Ohio State University, Wexner Medical Center in Columbus, Ohio. I imagine you're extremely busy given your specialty right now, so thank you for finding the time to join us, and welcome, Carlos.
Hello, thank you so much for having me.
To frame today's episode, let's start by reviewing our first learning objective, which is to identify best practices for screening for HBV in the emergency department. Our second learning objective is to facilitate linkage to care when managing patients with HBV in the ED in order to foster patient education and optimal treatment outcomes. And certainly a point of care opportunity to test for hepatitis B in the emergency department provides a great opportunity, but must also be linked or coupled with linkage to care. So Carlos, let's begin with a quick overview of who should be screened for HBV.
Sure. When we think about the groups at risk of acquiring hepatitis B, we can think about the modes of transmission of the virus. So for example, we worry about patients who may acquire hepatitis B through vertical transmission. So persons who are born in countries with high prevalence of hepatitis B, pregnant women from those countries, and of course, infants born to hepatitis B infected mothers. When we think about sexual transmission as an important mode of transmission for hepatitis B, we worry about men who have sex with men and known contacts, sexual contacts of people who are carriers of hepatitis B. And then, of course, thinking about
now, knowing who to screen for HBV is half the battle, as it is also important to know how to screen. And of course, for our primary care providers, medical students, residents, and really everyone except for those like you and I who are thinking about this every day, the alphabet soup of testing for HBV can always be confusing. But what guidance can you provide to our audience about the key serological markers for HBV and how to interpret them?
Yes, so there are basically 3 serological markers that are key that can then give us the picture as to whether a patient is susceptible to hepatitis B but not infected, whether somebody is already infected with hepatitis B and has chronic infection, or whether they're immune already. So these markers are the hepatitis B surface antigen, and this is the protein that sits on the surface of the hepatitis B virion, and that's a marker of active infection. Then we also look at total hepatitis B core antibody or anti-core hepatitis B antibody. And then in that case, that tells us that somebody, if it's combined, for example, with surface antigen, that may indicate active ongoing infection. And then hepatitis B surface antibody, which is a marker of immunity. So when we interpret, we look at these 3 markers and we can interpret the status of the patient.
Well, that's really clear and concise. Thank you. So the next step is to actually interpret these lab results. of those markers. How do clinicians determine if an individual is currently infected, susceptible, or previously exposed and immune?
So we start off with hepatitis B surface antigen. So if hepatitis B surface antigen is negative, then that indicates that very likely the person does not have current ongoing infection. So for example, somebody with hepatitis B surface antigen that's negative and hepatitis B surface antibody that's also negative and negative core antibody. So this person has not been exposed to hepatitis B and actually would be a good candidate for vaccination. But on the other hand, if somebody has positive hepatitis B surface antigen, then that indicates that there is active infection. And what we may see is somebody with hepatitis B surface antigen and total anti-core antibody that's also positive, indicating chronic ongoing infection. But in that case, the hepatitis B surface antibody would be negative since the person has active infection and would not be immune. If we have somebody with negative hepatitis B surface antigen, but a positive hepatitis B surface antibody, and then that indicates that the person is immune. If they also have hepatitis B core antibody that's positive, it indicates that they actually were exposed to hepatitis B, but they have now cleared it and they are now immune. If they only have hepatitis B surface antibody without hepatitis B core antibody and without surface antigen, then that person has been vaccinated. It just tells us it's a marker that somebody has been vaccinated. So it's by looking at the combination of these three results, then we can interpret what the status of the patient is and whether they require vaccination or if they should be worked up for possible treatment for hepatitis B.
Well, that is a really clear summary. Thank you so much. The interesting thing is that, you still see patients from time to time who present with a panel that includes a positive core antibody and a positive surface antibody, and they say, "Oh, I was immunized, so I was vaccinated," and you have to explain to them that the positive core indicates that they have been exposed to the whole virus. So moving back to the emergency department, it presents a critical opportunity for HBV screening given the number of high-risk groups that may be present there and may present themselves for care there. Is there any evidence to demonstrate a cost effectiveness of HBV screening?
Indeed, there is. So we know that the cost effectiveness of any public health intervention is very much dependent on the prevalence of the condition in the population. So obviously, if the prevalence in the population is very low, then an investment in a public health intervention may be very costly. But we know from studies that have been done in the US and in different countries in Europe that even at relatively low prevalence rates in different countries, that interventions that would promote testing in the emergency department can be cost effective. For example, recently there was a paper that was published about the experience in the UK, looking at screening for hepatitis B in emergency departments. And even with a prevalence in the population as low as 0.25%, the intervention of screening was considered highly cost effective. So in the range of 10 to 20,000 pounds per quality adjusted life year gained as a result of that type of screening. We have similar data actually from the US, but in particular when it's focused on the high risk populations, then we see very similarly that even in areas where there may be a prevalence in a population as low as 0.3% in terms of prevalence, that we see very cost-effective and even cost-saving interventions that can be put in place. So, for example, there was a study that by Chahal et al. In 2018 that's very specifically looked at the high-risk groups in the U.S. So Asian and Pacific Islanders, so foreign-born Asian Pacific Islanders who were living in the U.S., Africa-born Blacks living in the U.S., men who have sex with men, incarcerated persons, and people who inject drugs. And looking at each of these subpopulations, it was very clear that the intervention of screening for hepatitis B, but even screening and looking only for actively infected to potentially link to care and start on treatment was highly cost effective for all of these populations. If you add to that screening to also identify those who are not actively infected, but who are susceptible and then who would benefit from vaccination, then that was also cost effective. So putting the two together and in a very inclusive strategy of identifying both actively infected and those susceptible who would benefit from vaccination, that was even more cost effective. So for example, when they looked at people who inject drugs, the incremental cost effectiveness ratio expressed as the cost in dollars per quality adjusted life years gained was about $8,514. And you could adjust that. So if you looked at an older population, or if you looked at for example, a higher rate of completion of vaccination for those who are susceptible among the people who injected drugs, you had a whole range that went as low as about $6,500 all the way to $24,000 per quality adjusted life year gained. But what does that mean? That when we look at these interventions, anything that's less than $50,000 is considered actually highly cost effective. So for all these populations, these were well below that threshold and were all considered highly cost effective. So it does make sense, and it is in fact cost effective and even cost saving to screen for hepatitis B in high risk populations.
Well, that's very impressive. I remember the 50,000 number, and that was always a threshold at which you have a make or break return. And if you're showing that these numbers can be as low as 8,500 per incremental per adjusted life year saved, that would be really extraordinary. And you just wonder why it hasn't been done, particularly because I think there's an assumption that everybody's vaccinated. But in fact, as you point out, there could be people who have unstable situations, who may not have access to healthcare. They may have received one dose at the time of birth. This may not have happened if they were born outside of a hospital setting. And of course, we have a very large, foreign-born population. We published this in 2012 and showed that the contribution of the foreign-born to hepatitis B was potentially 800,000 patients, and so the prevalence of hepatitis B may be as high as 2 million, higher than, much higher than what is expected based on not including foreign-born population. So very impressive and new data. So now that you informed our audience about the serological markers and the, to me, unequivocal cost effectiveness of screening, how can emergency department physicians implement a screening protocol into their workflow? And I believe you have some thoughts and experience with this.
Yes. At my institution, we started doing some work with our emergency department colleagues that specifically started with trying to identify patients with HIV, and also in the Columbus area, we've had a very large syphilis outbreak for a number of years. And what we found is that a number of patients who eventually tested positive for HIV and syphilis had come through the emergency department on multiple occasions. So we considered these missed opportunities to be able to screen and identify patients that should have been linked to care much earlier. And so we worked with our colleagues in the emergency department to try and put together a program that would allow us to then improve testing initially for, as I said, HIV and syphilis. So we focused primarily on patients who were coming in for STI-related complaints, so sexually transmitted infections, and those types of complaints that would then signal that maybe they should be also tested for HIV and syphilis. So we set up an order set that would make it very easy for providers to then order the appropriate tests. We also then set up a specialty support group that was made up of staff in my division, so infectious disease doctors and nurse practitioners, as well as a team of internists and even pharmacists. And then we worked with our IT department to get a daily report of all the HIV and syphilis tests results from the emergency department. So on a daily basis, we would get these reports. And then we would be able to then quickly identify anybody who had tested positive within the previous 24 hours. And that would then trigger a direct contacting of the patient and linking them to care. So for example, if they tested positive for HIV, we would link them to care in our infectious disease clinic within 7 days. Or if they tested positive for syphilis, then we would bring them back, arrange to bring them back so that they could be treated for syphilis. And also as part of that, they might there would be a discussion about pre-exposure prophylaxis, so HIV PrEP that may be indicated for those patients. So then that actually worked very well. It helped us to identify a number of patients who had syphilis and HIV and then appropriately linked them to care without adding a burden to the emergency department. So this didn't fall on the emergency department providers who would then have to follow up on results. Our specialty team then would actually take care of result interpretation, contacting the patient, and then linking them to care. So logically then, as we looked at the risk factors in the patient population that we were identifying in the EDs, then we added to that also hepatitis C testing and eventually also hepatitis B screening. So what we did is, we added to the order set, depending on the population that was identified, the EMR then would help to flag for this, consider, adding hepatitis B screening to this. And then the order set would include the testing. So at my institution, this meant that we could look at patients at risk for hepatitis B. And so again, that population that are foreign-born, Asian or Pacific Islanders, Africa-born Blacks, previously incarcerated, people who inject drugs, men who have sex with men, and refugees. And then the provider could then add or remove that testing if they didn't feel that it was indicated. So the testing and screening, started to increase. And again, it was actually relatively straightforward in that the testing would be done at our institution. That meant those 3 serological tests that we talked about that would be part of the panel. So the hepatitis B surface antigen, the total core antibody, and the surface antibody. So looking at those 3 results, then we could interpret that if somebody had a positive surface antigen, our team would contact the patient. And if the patient had a primary care provider, although many of them did not, which is also why for many of them, they depended on the emergency department to deal with health problems that they had. So then we would contact the patient, link them to care rapidly, and then confirm the diagnosis and counsel them and treat them as needed. Or if they tested negative, if they had a hepatitis B surface antigen that was negative, and also a negative hepatitis B surface antibody, then that indicated that these were candidates for vaccination. So we would then let them know that they were not immune against hepatitis B, that they were they were at risk of possibly acquiring hepatitis B. So it would be a good idea to vaccinate. So this is something that has worked well, and then the emergency department has been happy in that it didn't require extra work on their part, and it's allowed us to then identify patients who, the vast majority of whom actually may have been unaware of the fact that they had chronic hepatitis B, or that they were not immune against hepatitis B, but maybe should consider vaccination.
Yeah, congratulations. What a great accomplishment. So you can imagine that there could be members of our audience who work in similar settings, would very much like to incorporate this kind of screening strategy and linkage to care strategy in their own hospitals. We have pretty much every community that has any level of an urban population now has people who are foreign-born and refugees, etc. Are there things you've learned from having set this up that were obstacles or challenges that you encountered, and other tips that you might provide to those that might want to set this up in their own hospital in terms of either process, buy-in from the ER providers, and then getting the linkage? I would imagine that this population may have financial and other types of insecurities, would be have a higher percentage of vulnerable patients. And so this would be a resource-intensive effort. What can you kind of briefly tell us what were some of the big challenges and how you worked around them?
Sure. So initially, and I want to emphasize that it's essential to, have the buy-in from the emergency department staff. So in fact, this project was actually set up from the beginning as a collaboration between the emergency department team and then our infectious disease team. So and also, we surveyed the emergency department first to see, would they be willing to do this? Is this something that they thought, actually had a role in the emergency department? And the responses from the surveys were very clear that they all agreed that this is something that would be beneficial and that should be done. But there were concerns about, potentially having an extra burden of having to notify patients and then link them to care. So once it was clear that the project would not add to that burden, then the implementation was much easier. So the providers were much more willing to then actually order the testing. The next part then was actually on the linkage to care side, and you're right, it does require an investment in use of resources. Actually reviewing results and interpreting them was not that time intensive or that difficult, since for our group, this is pretty much something that we do on a regular basis. So it didn't that wasn't the difficult part. The next part of contacting the patients and then linking them to care. Many times we would have conversations initially, and the patients were very much interested in, yes, I definitely want to come in and to get worked up, and thank you for the information, or if it was for vaccination. And sometimes it was usually a combination of discussions about possibly HIV PrEP. So for example, for patients who may be good candidates for PrEP, who were also had not been vaccinated for hepatitis B. So then that was sort of a combined discussion. But what we found is that sometimes that phone conversation would happen, but the no-show rate would be high. So a more recent step that we've taken is actually to incorporate the help of a patient navigator who helps to contact the patient and also to identify barriers to the patient coming in, so such as transportation issues, and can help with that. So it does require, the good use of resources, and also, we want to make sure that we're not adding, that there isn't a cost that then will end up falling on these patients. For many of them, they are uninsured, or some of them qualify under certain funds, or they may qualify actually for certain types of insurance. And here in Ohio, we have a program, for example, to provide PrEP to patients who are uninsured. So there are a number of different funds that can be tapped into, and that is obviously very much something that has to be done locally. So we continue to optimize the project, and then we review results regularly, and then we look at areas where we can improve things and actually make it a better experience and easier for both patients and providers. So it's definitely a work in progress. But I encourage everybody, our audience, to explore the opportunities in their own settings. And I can tell you that the emergency department, especially now in the times of the COVID pandemic, is a very important and potentially the one point of access to healthcare for a number of patients who may be at high risk. So I would encourage the audience to explore those options, have discussions with their emergency department colleagues, and then to start off from there. But this, it took some time, and as I said, we continue to work on this, but we're seeing good results, and we think that this will have a good impact.
Yeah, no, it's truly admirable and an important, very important service you're providing, and showing a path and a way forward for others to emulate. So, Carlos, thank you for providing us with a great discussion on opportunities for HBV screening and linkage to care in emergency departments. Now let's close with our SMART goals, that is specific, measurable, attainable, relevant, and timely goals. What key messages, Carlos, would you hope ED clinicians listening today will take away from this podcast?
So I encourage you to think about your patient population and to consider screening for hepatitis B in high-risk patients in the ED to reduce transmission and also to improve the quality of life of those patients. You should utilize the hepatitis B screening in the ED as a cost-effective opportunity to identify patients with chronic hepatitis B who should be linked to care for possible treatment, and also to identify patients who may be at risk, but who may be susceptible and not immune, who should be then referred for vaccination. And then add hepatitis B screening to STI and hepatitis C screening in the ED. Because of the modes of transmission, then a lot of these screenings go well together, and then it allows you to then target and identify patients who may be at risk for hepatitis B, hepatitis C, and possibly HIV and other STIs as well. And then work to officially incorporate the multidisciplinary teams to review test results and link patients to care without overburdening ED clinicians. This is something that is doable. So it's important to explore how this can be done at your own institution.
Well, that's fantastic. And I think it obviously shows the passion and expertise that you have brought in assembling this team and helping to make this happen. So thank you, Carlos. And then to receive CME CE credit, click on the link identified here to complete the post-test and evaluation online. Thank you for joining us today for episode 3 of our 4-part CMEOCast series. To view additional episodes and community-based efforts to improve screening and treatment of hepatitis B virus, please visit CMEOutfitters.com. And thank you again for participating, and thank you for providing the best care for your patients in this very difficult time.